on the anesthesia circuits. So this is one of the very basic topics which each one of you would get either in a viva or in a basic sciences of anesthesiology as a long note, or to describe any of the circuits which I'm going to discuss today and on 16th for a short note as well. And in viva, you can be asked about functional analysis of each and every circuit which you are actually reading, and functions of each part of, or what are the specifications for each part of these anesthesia circuits can be asked in any viva question which you're going to face. And it will be a lifelong lesson for each and every one of you to know about these anesthesia circuits. So basically, what is the anesthesia circuit is? So just a second. So basically, what is the anesthesia circuit is? It is an assembly of components which basically connects the patient's airway to the anesthesia machine, and it is from the this is the artificial atmosphere from and into which the patient will breathe throughout the anesthesia which you are administering. So this breathing circuits, basically you have to know the history of how these breathing circuits evolved before we jump into the actual breathing systems per se. So somewhere it be given as 1917 when Sir Evan McGill actually devised the McGill circuit, which is now present as Mapleson A circuit. And somewhere in Anesthesia Museum, it will be given as in 1928, Sir Evan McGill actually devised the Mapleson A circuit. And in 1927, the Raphael Milton Walters devised this to and fro system of carbon dioxide canister. This became very popular at that point of time because this canister can be autoclaved and it has a carbon dioxide absorber as well. So those patients who have got a respiratory infection such as tuberculosis, they were using this machine in particular to autoclave it and then use it so that they can prevent the infection which can occur from patients to patient if they are using the anesthesia circuits. And in 1937, Phillips Ayer was the one who devised the specification for pediatric system as the ISTPs. Before then, there were no gross circuits which were available for pediatric population. There was Mapleson A, B, and C, but there was no pediatric population could be served through that circuits because it would drag the endotracheal tube, and lots of efforts for spontaneous ventilation as well as controlled ventilation was there with all the Mapleson systems which were available back then. And if you have to read about Ayers, he is a very peculiar person who has got a cleft lip, cleft palate himself, and I think he got operated also. He is a very great person in whom he has suffered so much of personal losses, yet he made this ISTPs in a beautiful way to help people, to help the pediatric population who would get anesthetized. And the revolutionary discovery was by Bain Circuit, whom he devised a closed system, closed circuit. And this closed circuit is being modified and used nowadays with the carbon dioxide absorber. And this person is the person behind it. And one should not forget about the Mapleson system, which was devised in 1954. And William Mapleson gave actually 5 systems like A, B, C, D, and E. And E's modification becomes the Jackson-Rees modified the circuit E to make it as Jackson-Rees circuit, which is F circuit. And this was a like milestone article which was published in British Journal of Anesthesia. If anyone would be interested to know about how Mapleson classified all these systems, we can go through this landmark article in BJA. And this is another landmark article which was given by Dr. Bain and Sporel, who they both devised the Bain circuit which we are using now, which is again a modification of Mapleson D circuit. And this circuit was long enough, and this enabled the scavenging system for actively scavenging the anesthesia gases which are there in the which we are using day in and day out. And William Sporel as well as Bain showed that, as you can see in this picture, they showed that scavenging also is possible through the suction system. And they also anesthetized patients with cleft lip and cleft palate with Bain circuit and proved that without effective rebreathing, patients can be anesthetized using Bain circuit, which is again a modification of Mapleson D. And based on these anesthesia circuits, these anesthesia circuits have a requirement which they should meet before using it up to a particular patient. There are essential requirements and desirable requirements. The essential requirement is the one which have to be met for anesthetizing the patient. So the primary requirement will be it should deliver the anesthetic gases as well as the fresh gas flow at the same concentration in the shortest time possible to the patient. And these circuits should eliminate the carbon dioxide which the patient is producing as and when possible without a possibility of inhaling the carbon dioxide which the patient is expiring. And the apparatus should have a minimal dead space apparatus dead space as possible, and these systems should have a very low resistance. So these are the essential requirements for the anesthesia breathing circuits. And the desirable requirements are it should actually consume less fresh gas flow. It should have conservation of heat, and humidification of inspired air is one another desired quality of a breathing circuit. And it should be lightweight, inexpensive, and it should be convenient for your usage. Like you should not hold the mask, have a tight fitting mask, and the circuit should not drag you down or drag the endotracheal tube down because of its weight. So it should be convenient during usage. Whether it is spontaneous or controlled, it should be efficient for both. And it should be useful for both adult and pediatrics. And there should be an effective scavenging system, like as you can attach through veins, a suction cannula or a suction apparatus at the APL valve to vent the anesthetic gases, so that will minimize the theta pollution. And you should prevent the patient from barotrauma. And as I said, it should be inexpensive. And these breathing circuits are classified as two ways. One is drips and another is the Conway. And the Conway is a modified Conway. So the drips devised these breathing systems based on the volume of reservoir and the amount of rebreathing that is allowed within the circuit. So this system is not used nowadays because of the obvious disadvantages, where he classified the systems into open, semi-open, semi-closed, and closed. So in open system, there is no reservoir and no rebreathing. In semi-open, there is a good reservoir, but there is no rebreathing. And in semi-closed, there is a good reservoir and a partial rebreathing. And in closed, there is a reservoir and there is a complete rebreathing. So what are the examples of these are? Drips gave it as the open method is open circuit is the one, which is a ether by ether drop method, which is a Schimmelbusch method. But do we really see a circuit in Schimmelbusch mask? No, it is just the mask which is held and a cloth which is put, and then the ether is given as an open drop method. There is no circuit which is involved in a Schimmelbusch mask. So this is again the first thing itself became an obsolete one. He classified Mapleson A to E as semi-open. But some of them came with the notion that how can it be a open system when the APL valve is partially closed and you are allowing a partial rebreathing. So, and that again led to a controversy. And there is another system called as a semi-closed system. So what Drips did was, he said partial open APL valve in a closed circuit or in a complete circle system is a semi-open, semi-closed circuit, and a completely closed APL valve belongs to a closed circuit is what Drips told. So the obvious disadvantages are the Mapleson system itself can act as a semi-closed one as well as semi-open one, and there is no clear-cut data which says this system belongs to this, and there is no circuit which is involved in the open drop method. So then came the modified Conway. There are so many methods of classifying, so these two will be enough for us to know. And modified Conway is the one where he classified the breathing systems into two, without carbon dioxide absorption and with carbon dioxide absorption. So based on the flow, if there are any flow control valves or unidirectional flow is aided by a valve, whether it be a Rubin valve or an unidirectional flow valve. So if there is a unidirectional flow valve, then it is a unidirectional system. If there are no valves and the fresh gas flow as well as expired is flowing bidirectionally, then it becomes a bidirectional flow. So with carbon dioxide absorption, the unidirectional system is the circle system, and the bidirectional flow system is the Walters to and fro canister. And in breathing systems without carbon dioxide absorption, the unidirectional flow is a non-rebreathing system. And in bidirectional flow, we have got the Mapleson's A, B, C, a lax system, and the Miller circuit and the Humphreys ADE system. So this is the bidirectional flow